Well, it's so good to see so good to see so many of you for I don't know, our third NPPCE session of the year. We are just super well, me especially, but also Catherine and Naomi are super excited to be hosting Justin Bullock today, who we put his bio in the invitation, so I'm not going to embarrass him by reading it again. But just to say that Justin is a recently graduated nephrology fellow who's working on his PhD in medical education. And I think I'm particularly excited to hear Justin talk today because I think he's really bringing a fresh perspective to many sort of long talked about concepts like psychological safety in medical education. And he's kind of going to bring us, I don't know, something new and different to think about. So I'll hand it over to you, Justin, and thanks again for being here.
Thanks, Amy. Thank you very much for letting me join. Thank you all for joining during your lunch. Please turn your cameras off if you want to. It's perfectly fine. Yeah, I'm really excited to get to join you all today. I think of my PalCare colleagues as extremely thoughtful and nuanced in the way that they think about how they show up in caring for patients. And so I'm very excited to get to present some work that I think might be a little bit provocative. I come from the land of the kidneys, which is certainly different. So I'm going to spend a lot of time, we're going to talk about psychological safety, identity safety, and disclosure. My hope is that this will be very interactive. Hopefully I will only talk for like 30 minutes and then we can really like engage. I'm very welcome to questions as we go. So I call this disclosure an unprofessional step towards identity safety. So I'll start by saying that the human being is a storytelling being. We make sense of the world from the stories that we tell. We make sense of our world in relation to other people. I spend a lot of time thinking about identity, and inherent in the concept of identity is the formation of an in-group of people who you are like, who you share an identity with, and the formation of an out-group, people who are different from you. To think about identity, I think through a critical theory lens. Critical theory has been sort of a hot topic in the news recently because critical race theory has been is viewed as controversial in some places. But what critical theory really does is it looks at power and specifically how power is linked to identity. And most critical theorists, their goal is to, one, unpack and understand how power is linked to identity and how that leads to, disparities or differences or challenges throughout society. And then also really thinking about how we can sort of reallocate power or disrupt the conventional power dynamics to make a more human, just society. There are many different forms of critical theory. Here, there's just a few: critical race theory, feminist theory, queer theory. There's discrit, quant crit, etc. Like really any identity you can kind of think of, there's a related critical theory branch. And I'm going to spend a little bit of time at the beginning really trying to deeply orient you all to my sort of lens, the theoretical paradigm and approach that I bring to my work, because I think that you will see the ways in which this orientation comes out through the work as we go along. So in order to orient you all, I'm going to sort of take you through a timeline of the sort of intellectual lineage from which I orient myself. And then I will reflect on it in a bit. So first, most left, we have Karl Marx. Many people hear about Marx in high school. His sort of description of the ruling class and the sort of commoner class, the bourgeoisie and proletariat. And what Marx says is the ruling class controls the economic means of production, and the sort of commoner class provides the sources of production, but through their sort of labor, they never become they don't ever control more of society. They just sort of invest their labor into the system, and the ruling class becomes more and more dominant. So next there's this guy, Antonio Gramsci, and this is where sort of the academic space enters. So Gramsci is in the Marx lineage, and he sort of builds on this economic ruling class and says that the economic ruling class is also the intellectual ruling class. And if you look throughout society, society changes according to the intellectuals. And he says, even when people don't come from the ruling class, through the process of education, we actually socialize them into being more like the ruling class. So you take them from the environments that they're in and you bring them into educational settings and you indoctrinate them in ways such that they no longer represent the communities that they come from, and instead are now a part of this ruling class. Then there's this guy, Paulo Freire. He is sort of the father of critical theory. His book, Pedagogy of the Oppressed, talks about this notion of the oppressor group and the oppressed group, and says if you look throughout society, you'll see these constant struggles between the oppressors and the oppressed. He argues that the only way to truly humanize or liberate ourselves is to leave this oppressor-oppressed dynamic and to more truly focus on humanization. And again, I will get to this topic of safety related to people's identities, and I hope these principles will come out more clearly. There's this gentleman named Derek Bell. He is one of the fathers of critical legal studies, and what he does is what he's known for. One thing I think is very memorable about him is he uses actual fictional stories as a way to sort of grapple with very complex or sort of controversial topics like race and racism. And he argues that through using this storytelling method, we can allow people to grapple with topics that they maybe couldn't sort of directly talk about without using in story form. So one example of this, one of my favorite stories from him is he talks about one of his stories is like aliens arrive to Earth and they have the ability to cure all disease, end global warming, all these things. And they say that they will do this for the United States if the US is willing to give all their Black people to the aliens to be taken away. And then basically uses that sort of narrative and what happens in the country to try to unpack sort of race and racism. Next, we have Bell Hooks. Bell Hooks writes about many things, and she was a Black woman feminist. And one of my favorite things that she writes about is this notion of true feminism. She says that most people who call themselves to be feminists are not actually feminists because they write in a way that's inaccessible to the common woman. And in so doing, if the common woman were to read their work, they wouldn't see themselves sort of in this work and wouldn't feel empowered. And argues that we really need to use language and practices that are much more accessible to people. Next, we have Kimberly Crenshaw, who talks about intersectionality, that she's also a Black woman, and in the Black woman feminist sort of intellectual lineage, who talks about the experience of being a Black woman is more than just the sum of being Black and being a woman. Both in positive ways and challenging ways. And finally, to the most recent, this is Django Paris. I didn't have a black and white picture of him, but he's not in color for any particular reason, except for I couldn't find one. He's actually at the University of Washington, which is where I am also. He is known for sort of describing this culturally sustaining pedagogy. He says that, most of education, we are taught to tell people stop doing this and start doing this. So it's subtractive. When people enter elementary school, they're told don't use these slang words, use these proper words. And what happens is sort of resembles this process of extraction that Gramsci was talking about, where people lose their ability to connect to the communities from which they come from because of the way we sort of conduct education. And he argues for a more sustaining form of education where we build on top of what people have, and really sort of utilize and leverage the assets, the cultural wealth and identity capital that they come into work with. this is sort of my orientation to this work. And I hope you will see it come out as we go. So I mentioned that I study identity. I would argue that identity matters a whole lot in medicine. There's all sorts of research talking about identity threats, about the ways that people's identities are called into harmful play in the learning environment. Professionalism, this process of medical training is said to be one of developing a professional identity. This is the professional identity formation. And recently there's been a lot of sort of questioning about what it means to be professional and how some of our cultural norms within medicine reflect the social norms of only a small subset of people, and it doesn't reflect the diversity of providers that exists now. And then, within picking any sort of field within medicine, you often hear this phrase of "go where your people are." And inherent in these statements is this is identity of going to be places, and the end effect is that we end up with more homogeneous groups because people tend to only go in places where they see themselves well reflected. And this notion of professional identity formation is something that I am very passionate about because I think a lot about how we train providers and how that impacts the care that we deliver to patients. This is a very complicated figure. I only show it to say this is sort of like in the meta literature, this is like the professional identity formation figure that everyone will cite. And in it, it says that people come in with their pre-existing identities, and then those identities go into this black box, which has all these inputs, and through this sort of mysterious process of socialization, you end up with a person who's negotiated some of those old identities and now has this new professional identity. So I challenge this image for many reasons, but I think most importantly, as someone who studies identity, I recognize that one's identity is not just an input that just happens to go into this process of medical education, but that your identity heavily influences the role models and mentors that you pick. It heavily influences your experience in the learning environment. It heavily influences your relationship with patients. It influences your clinical and non-clinical experiences, and so really identity is actually involved in every single one of these arrows. And there's actually a lot of literature supporting that as well. And so I think it's important that we unpack the sort of dynamics around identity in the learning environment. I mentioned this term, identity threats. Identity threats refer to within the individual, between individual, or structural ways that people's identities come into play in harmful ways. So like intra-individual could be internalized homophobia. Between individuals, microaggressions or stereotype threat, and structural racism, sexism, xenophobia, etc. There's a host of literature that says that identity threats, they sort of are emotionally impactful, and this is both for identity threats for patients and for providers. And second, they impair they consume our cognitive load. So your ability to think and reason through tasks, to do intellectually challenging things is limited when you're experiencing identity threats. One of the big beliefs in critical theory is that there's no such thing as objectivity, and the lens with which people come to the work is one of the most valuable aspects that they bring. I believe that to be true in medicine. I certainly believe it to be true in research as well. And so in the spirit of that, I want to share a little bit about myself. So I am Black. I have bipolar disorder. I'm someone who identifies as having active bipolar disorder, which means that, I haven't triumphed over my bipolar disorder, that I have mood episodes, that I've been hospitalized many times during my medical training, both as a med student and a resident. And that this is something that is a very important aspect of who I am, and really shapes my interactions with patients. And I will say that there is sort of not everyone believes that I should sort of be vocal or visible about my identity with bipolar disorder. There are some people who think, so this is from a talk that I got to give. And after that talk, there was someone who said, I worry about this person's ability to provide safe care for their patients because of the way that I talked about how I draw my bipolar disorder into the work that I do. Yeah, and this lens very much sort of influences the way that I think about safety and identity threats. So the last thing before I get to safety, which is where I want to spend most of the rest of the time, is there's a lot of literature that talks about identity threats, which I've said. And most of the literature that talks about safety related to identity, it would be something like someone would describe a study where a microaggression happened and then someone intervened. And the research will call that an identity safe condition. We challenge that notion of safety because when you talk with learners and you ask them, something bad happened and someone responded, would you call that safe? They would say, no, it dampened the threat. It helped to mitigate what happened, but I still didn't feel safe. And so we call that term threat mitigation. And there are things that people can do for themselves to help to mitigate threats. People learn how to act or behave in ways that to respond to threats or to prevent them. And there are also things that other people can do, that allies can do to help to reduce threats. But again, I would say responding to threats is not safety. I asked the question to you all, like, what if we centered safety? Thinking back to the sort of oppressor-oppressed, many people could argue that centering identity threats actually centers the oppressor, the person who's causing harm, whereas centering safety centers the oppressed, the people who are more likely to be harmed. I'm sure many of us have heard about psychological safety. I would argue that it's the dominant safety paradigm that exists in medicine. And psychological safety focuses on power hierarchies and says that, in environments in which there is a big power differential, in which people don't feel psychologically safe, don't feel safe to sort of challenge that hierarchy, they're less likely to disclose errors, to challenge their leaders, to speak up for things when they feel like things aren't right. And I guess this is my first place where I want to pause and ask you all a question, which is, I'm curious to hear what types of conversations around psychological safety you all have in your respective communities. I'll pause there and would love any comments. Please, Karen.
So we've had quite a few conversations about this topic. One thing that I think needed to do was to allow people to report their concerns anonymously. And that, I think, really changed the landscape of people being able to come forward with really any kind of any issues they were having. Prior to that, there was a lot of discomfort and just kind of airing concerns about psychological safety. So just conversations about psychological safety were sort of muted by, I think, fear around psychological safety, that they didn't want to be the one to say, I have a concern about this. And being able to put concerns to put them out there anonymously, I think really helped to raise some safety around that conversation. And then more and more people became more comfortable talking about it, where they felt safe, where they didn't feel safe. And I think what became apparent was that there is a lot of sort of top-down fear from the bottom up, like fear from managers, or fear of talking in front of managers, fear that when things are reported to managers that things aren't necessarily addressed. So yeah, I think that's kind of where our conversations have been, trying to just encourage people that there is support and it is important to come forward with concerns. And we do want it to be a safe environment, and it's never really okay to, to feel bullied or to feel called out in an unsafe way. So we're working very hard to kind of improve our culture there. I'm going to also, Jared, I'm going to put you on the spot there. We had Jared come and speak to our group too about this topic. And I think that also really helped to spear some more conversation about this topic as well, to encourage people to support each other when they view others potentially being maybe put in a situation where maybe it wasn't safe, and to sort of speak up to support their colleagues. I thought that was a really, really helpful pearl that I learned from Jared Rubenstein. I'll just put that out there.
Thank you. Yeah. So challenges, so psychological safety challenges in discussing psychological safety. Yeah, thanks.
I'll add, Justin, I think I'm not sure if this is right or fits with the official definition, if there is one, but when I think about psychological safety, I think about it a lot as paired with the growth mindset. Like in order to grow and learn and get better at things, you sort of have to feel like it's safe to make mistakes and learn from them. And I think that is reflective of most of the conversations I feel like I've had, at least in an educational space, around this concept.
Yeah, absolutely. There's all this literature that shows that it's when people are psychologically safe, they have more of a growth or mastery-oriented mindset. And Amy Edmondson, who's sort of the foremother of psychological safety, you know, her early work basically was saying that she noticed that in the highest performing units, people were more likely to disclose errors, which maybe was counterintuitive to what a lot of people thought that would happen. I guess I'd say maybe ask for one more person. Something that Amy and I think we talked about before this is there's certainly a lot of psychological safety comments around medicine within the sort of professional hierarchies, and especially on interprofessional teams, of which many palliative care, I would say almost all that I've ever interacted with, are. Power exists in kind of complicated ways often, and that can be navigated more or less well. So I would say I love psychological safety, but I think it has its limitations. And I'm going to give you two that feel relevant for me with my work in identity. The first is, in psychological safety, you always need someone, the person who's in persons in power, to make the people who are less in power feel safe. So typically it's like the boss, the senior most person, someone who has some sort of hierarchical power already, they do things to make others feel safe. And it's never that the person who's sort of at the bottom of the pyramid is able to generate psychological safety for themselves. And in that way, there's a lack of agency among the people who aren't already in power. The second critique that I would give around psychological safety is, as it's written and described, it's very identity agnostic. And by that, I mean, psychological safety literature would say, you know, once someone feels psychologically safe, then they'll bring their diversity of their identity. And what our research would say is, even if hierarchy is addressed, if it doesn't feel safe to be a Black person, people aren't going to bring the benefits of being Black to their communities. Yeah, we'd say to address identity, you need to attend to identity. So I'm now bringing you all towards this notion of identity safety, which are two words put together. It seems like it often will make sense, but I want to give you the way that we define or conceptualize it. We describe identity safety as a state where a person feels their freedom to be themselves, where they can exist as their authentic self without having to worry about others' perception of their identities, and engaging in something called impression management, which is when you're trying to control the ways that people sort of perceive or interpret you and your identities. And in the spirit of stories, I'll give one story that I think sort of most effectively describes identity safety or conceptualized identity safety. So this story was from an interview that I did with a medical student who was a Filipino woman. And she was telling me about how initially she was interested in going into one particular specialty. And she did a year of research in that specialty. And she said, it wasn't like they were mean to me. I just didn't feel like I fit in. A lot of my hobbies, they're culturally related hobbies, and I didn't see anyone who sort of shared my identity. It didn't feel like people would sort of like connect with that. She said, for instance, and there are a lot of ways I just feel like I couldn't be myself. For instance, I didn't wear my favorite purple scrunchie for a year while I was doing research in this specialty. And I asked if she had ever come back to wearing this purple scrunchie. She's like, "Oh yeah, I wear it all the time now." And I said, "Can you tell me about the first time that you decided to wear it again?" She said, "So I decided to not do that one specialty, the one where I didn't feel like I fit in. And now I'm in a new specialty with a lot more women, a lot more diversity. And one day I put on my outfit and it matched my purple scrunchie, and she showed me her like purple and pink water bottle. And she's like, and it matched my water bottle too." And she said, "This is so silly. That's why I don't like thinking about it. But I looked down at that purple scrunchie, and in that moment, I realized how much of myself I had suppressed over the last year just to try to fit in. And it's really nice not to have to overthink really small, dumb things like a scrunchie anymore." I love this story because, one, I think the visual imagery sort of really brings to light this thing that seems like it's like very small, but highlights how much of ourselves we often have to feel compelled to suppress in some way to try and fit in. And part of it is because we're taught that that's our professional duty, is to suppress these aspects of ourselves. And I want to spend some time sort of interrogating that. So for us, we say that identity safety has three main pillars. This image is supposed to sort of map the world of identity dynamics, that there's identity threats, which I talked about, threat mitigation, and identity safety. And identity safety, similar to identity threats, has within the individual, between individual, and a structural level pillar. Within the individual, we have what we termed agency to serve. This is the ways in which people draw on their own lived experience, their own identity capital in the service of patients. And for people who are in caring professions, the ability to draw on one's identities and experiences to help people is very grounding. It makes people, it sort of validates why people are in the right place. And in many ways, it gives them a sense of agency and power that they can help people. And in this way, compared to psychological safety, there are some times where the junior most person on the team can leverage their identity in ways that no one else on the team can, such that they are actually able to wield power that others cannot, even despite their sort of hierarchical position on the team. So an example of this is, we had one learner had type 1 diabetes, and they were seeing a patient with their attending, and the patient also had type 1 diabetes, and the attending said, "Oh, this isn't someone who I think of as a good candidate for an insulin pump." And the learner says, "Oh, actually, insulin, or like an insulin pump, is the standard of care for everyone. Everyone should have the opportunity to try it." And in that way, and the supervisor was receptive to that. And in that way, the person felt like, one, they got to help the patient, but two, they got to help teach a supervisor. And many people will talk about that these moments of leveraging their identities are actually foundational moments to why they went into a specialty. There's another learner who decided to go into psychiatry, and they talked about one moment where there was a patient who was admitted to the hospital for suicidality, and one of the big things that was distressing them was sort of their parent, who is an immigrant, and them not sort of fitting their parents' perception of what they wanted. And this learner basically told them about this term, which they said is an outdated term, but called third culture kids, which are basically when people have to blend the culture of their parents and the culture of the country that they're in. And basically this patient said, like, "Oh, you really understand me." And they said this is one of the really foundational moments that sort of inspired them to go into the specialty. And I think many people have moments like this. Next, there's upholding personhood. This refers to times where individuals, they show you ways that they see your identities, that they value your identities, but they know that there's a person beyond those identities. So you all may know, from me giving this talk, that Justin is gay and Black and bipolar, but there's also a Justin who's more than the sum of those identities. Thinking back to intersectionality with Kimberly Crenshaw. And oftentimes people talk about, first I'm going to think about this from the training side, and then we'll think about it from the patient side. Within training, oftentimes there are these moments of sort of like sharing a meal with someone, which often is a very sort of humanizing time where people tend to not talk about patients because they're often in like sort of community settings where they can do that. And so they end up sort of spending more time getting to know people as humans. And finally, belonging. There are sort of two definitions of belonging. One of them refers to, being similar to. So I feel like I belong because I have identity concordance. And the second is I belong because I am welcomed as my authentic self. And we ascribe more to the second definition because I think everyone could say there are many times where we can share an identity with someone, but may not connect with them on a deeper or more meaningful level. And while it can be helpful to have identity concordance, it is not. It's not sufficient to foster safety. So this is our framework of identity safety. We argue that as you move throughout any clinical setting, you need skills both to foster identity safety and skills to mitigate threats. Because even if you create a perfectly safe team, you're going to interact with different patients, providers, et cetera, and inevitably identity threats may arise. And so you need both skills to foster safety and to respond to threats as they come. So I'm going to pause here and see if people have questions or comments. Okay. All right. So here we go. So I made this first point, which is, having someone who looks like you, externally, first there's people have many, many identities. Only some of them are visible. But the identity concordance is not identity safety. As we think about sometimes, there's a motivation when if, like it's happened with me before, there's been a Black patient who was mistrustful of the healthcare system. And then people have, wanted or have offered me to care for this person. And what we would argue, what identity safety would say is that any person can uphold another person's personhood. That identity concordance can be helpful, but our studies have shown that there are many times where people will have identity differences, but still were able to, make a person feel seen and valued as a whole individual. And the second thing is, when we think about upholding personhood, that's different. That is, upholding personhood is not tokenization. We would define tokenization as, one learner said, if the only time the team values me being from Mexico is when we have a Spanish-speaking patient, then they're not valuing me, they're tokenizing me. And that is different. People would describe it very distinctly from times where they felt like their personhood was upheld. Okay, so we're almost to disclosure, which I'm getting excited to finally talk about. This figure is from a longitudinal study where we're basically following fellows as they go from generalists to subspecialists. And we have a variety of fellows, including some folks who are in PAL care. And we often hear the term professional identity. I would argue that the term that we're typically using for professional identity is really the profession's identity. And it's used because usually professional identity is used as a very sort of fixed thing that, what it means to be professional, like professionalism is a sort of well-defined construct. But really what we see happening is every person has their own personal identity, the parts of themselves that exist irrespective of them being within medicine. And those are sort of negotiating with the profession's identity. And in each profession has, people most people could describe what it means to be there's a sort of image in their head that they have of a nephrologist and what makes a good nephrologist, of a good palliative care doctor, et cetera. And what happens is people must negotiate these things, and the end result is each individual forms their own professional identity. And there are some parts of ourselves that get pushed into our identity that are part of our professional identity, regardless of whether or not we want them to be. And there's some parts of our profession that we acculturate to, even if we don't like it, just simply from being in the environment that we are and hearing the same thoughts over and over and over, and those become a part of our professional identity. And we believe that identity safety sort of negotiates the boundaries between the things that you sort of easily bring into your professional identity and those that you don't. From each person forming their own professional identity, I want to introduce a term to you all called subjectification. So the way that I like to describe subjectification, I would first say, many people think of training as a process of acculturation, of becoming more similar to a group norm. Subjectification refers to the times where you actually step out of the group norm, where you do something that is different than what your profession's identity would say is typically acceptable, where you become the subject, someone who stands out because they are different than the group. And I would argue that disclosure is one form of subjectification, that often in medicine, we are very heavily sort of discouraged from disclosing aspects of ourselves, whether that's because we believe that we're sort of taught to believe that it wouldn't be beneficial to the patient, that we don't want to make the conversation all about ourselves, et cetera, et cetera, et cetera. But I hope to sort of give some examples that challenge that. Before I get to sort of personal things, I want to introduce the concept of intellectual candor, which basically refers to times where we admit that we don't know things, that we admit our intellectual weaknesses, our gaps in knowledge, et cetera. Some previous work that we've done around sort of responding to microaggressions and building a framework for sort of having identity-safe introductions. One of the key lessons that comes out is that for the people that learners say do respond to sort of microaggressions well, compared to those people who we call general faculty, who weren't nominated by students for being exceptional at this, those who are exceptional students that are exceptional at this are more likely to acknowledge their limitations and know that they're going to mess up and use those moments of messing up as opportunities to learn and to teach and to grow. So this is one form of disclosure, disclosing that you don't know something, and that is a form of subjectification of where people sort of differentiate themselves from what the group norm or group expectation is. And I see that some sort of comments dinging. If anyone has anything to say, you can feel free to just unmute, because my screen won't let me open them.
I was shouting out, Justin, in the chat, that sort of this like ties back to this idea of the growth mindset of like having the humility to know you're going to fuck it up.
Yeah.
And you're going to learn from it.
Exactly.
Cool.
Yeah. Exactly. Thank you. So, okay, so I want to share a story here. So, I am someone who over time has sort of become increasingly sort of disclosing of, and it's often related to, even though I'm a kidney doctor, I very often encounter patients who are really struggling with their mental health. It's not infrequent that I will share some aspect of myself. And one moment that happened recently that I really was sort of waffling about whether or not I felt like I did the right thing was I had a patient who was really struggling to take his medicines. And as he described to me sort of his experience, I got sort of this feeling that there was sort of a mental health sort of trauma aspect to him not taking his medicines. And I said to him, and his mother was in an appointment with us. He's sort of a younger adult. I said, if it's okay, I'm going to share something about myself. I have bipolar disorder. And I take medicines, and for me, sometimes, often, it's very sort of triggering for me to take medicines because it reminds me of ways I've tried to hurt myself in the past. And, for me, the result of not taking medicines is so much worse than the impact of taking medicines that I decide to take it. And, everyone sort of has their own different experience, but this person, I was highlighting, I think he understood very deeply that I think he wanted to take his medicines. He was just trying to find a way to do so. And so I shared this, and the patient, he didn't really say much in the moment. I couldn't tell whether or not it was received well or not. And this is the first risk of disclosure, is there is this very deep uncertainty of whether disclosing something, it's more often than not that you don't get a direct response to know whether or not what you did was helpful or hurtful. And there are some times, as someone who is sort of thinks a lot about disclosure, there are clearly times where I have disclosed and it has clearly not gone well. I'll give you another example, just so I'm continuing with examples. I once had a patient who I was seeing in clinic. It was his first visit after being in jail for a long time. And my father's in prison. And I basically made some comment oh, my dad was in prison. Some to try and sort of show him that I wasn't judging him or looking down on him. But that really wasn't something that was community building or empowering, or it very clearly didn't land well. I was trying really hard to find something similar between the two of us, and that didn't work. And so part of the risk of disclosure, just with any skill or any technical thing that you would do, is you inevitably will mess up, and you can learn from it. And as especially in as you all may imagine, I'm very curious to hear your thoughts about disclosure, because in particular, when I think about palliative care, usually it's because something is going less than ideally planned, and that can make disclosing complicated. And I guess I'll come back to that in a second. The other risk of disclosure, I'd say, is there is very, very, very little literature about how to disclose. There's some literature about people's perspectives on disclosing, whether or not they feel like it's good or bad. But something that we see in our learners is that people do disclose all the time, but they often do so in private, not around other people. And so therefore, there's really no clear best practices about what disclosing looks like. So I wanted to give one example of a form of disclosure that's a little bit complicated. That's really that's from our study with fellows, which is someone who's pregnant and working in a PAL care setting. And they said, I'm just feeling really aware of. I always feel really aware, especially in palliative fellowship, of how I and my actions make other people feel, specifically patients. And then I feel like this is just an added layer, and this being her being pregnant and her body showing, and that this aspect of there's sort of a disclosure that's happening, even regardless of whether or not this person wants to do it. It's just an added layer because if it's something I'm asking, or the way I'm saying something, I can change that or make myself a little bit more small, or something if I need to in a conversation, but I can't do anything about my pregnant body in this situation. And this provider also talked about the sort of complexity and that they felt that people, when they saw them, may assume that their pregnancy was a healthy pregnancy, which for this person it was, but just that there are so many layers of additional sort of nuance around this sort of forced disclosure that was happening. So the question I guess I would ask to the group, and I want to pause for a bit, is asking, how often have you had disclosure modeled for you? like, what would you all say is the palliative perspective on disclosure? I think many people would call it unprofessional. I would say, why is it unprofessional? Um, we often think about the sort of risks of disclosing, but we don't often think about the harms of not disclosing, of their opportunities where disclosing would do something positive, but we don't really think about those moments. And then, yeah, why is it just not something that we study? So I guess at this point, I want just like any comments or thoughts, and yeah, your perspective or experience with disclosure.
I can go. First, I'll say Justin, longtime fan, first time caller.
Likewise, likewise.
So a couple things. One is I think from learning from a lot of people who understand this better than I do, have learned over the last few years that, that with the weaponization of professionalism, like I think we have disclosure all the time. I think medicine has forever had, it has been normal to disclose whiteness, Christianity, heterosexuality, golf playing, like all of the things and like the stereotype of like what doctors have historically talked about. Like I'd argue that's disclosure too. And it's just normalized. And so it's all the non-normed disclosures that are considered unprofessional. And like I think bringing that out to the light is huge and hugely important. And I think normalizing what the sort of the more broader definition of professionalism is super important. I think from disclosure, I'll say for a couple things from myself. I've disclosed as a pediatric palliative care doctor once or twice when my first child was sick and was in the NICU for about a month, and I don't talk about it a lot. And particularly with our patients, because my child thankfully is doing great now and made it through and is completely fine. But every now and then I'll bring it up as a way to connect with families, and once or twice have brought it up with a family that the patient's mother was grappling with her own mental health stuff and struggling with what did it mean as a parent struggling with her own mental health while her child was in the hospital. And I shared that, how I struggled with my mental health while my son was in the hospital, and we talked about that. And I hoped it was helpful, but to your point, like you never really know. And I think I think we should, I'm just echoing, like I really agree. I think we should think harder about what's professional and what's normal disclosure, and acknowledge that we've always had disclosure. It's just always been a very, very narrow definition of what's been professional to disclose. And it's alienating to all the people that don't fit that.
Thank you. Yeah, I completely agree. There's this term in research, the 0-point perspective, which is this assumption that like we assume that not disclosing is neutral, but it's very much not neutral. It is not disclosing sort of not highlight, but it picks a certain set of paths, or it makes a certain set of assumptions that by not saying anything we don't challenge. Thanks. Please.
I was just reflecting, and I think it's interesting in peds palliative care in particular, or peds in general, the number of times that I get questions from families about like, do you have kids or whatever, which I feel like there's a lot of, in that space, a lot of inviting for disclosure in the pediatric space. And then the other thing I was thinking was that I am a pediatric oncologist, so have a lot of very intense longitudinal relationships with families, and have a child with autism, and have found that discussing that with families who have a child affected by autism has actually led to really good discussions and really opening things in a positive way. And I don't know if that'd be different if I didn't have the degree of longitudinal and deep relationships that I do with families, but in that situation, it's been very positive and supportive on both sides.
Please, Linda.
So I'm a psychologist in peds palliative care. So obviously have a very different perspective. We talk a lot about disclosure, throughout grad school and what's appropriate or not appropriate. Often most things are not appropriate. So we're often taught to figure out ways to respond to questions that turn it back on the patients instead of like directly answering questions. And there is some research about like therapeutic self-disclosures, but it is something that's hard because it isn't used very often in the field. And so I think that's part of the challenge. But the other piece is the self-awareness that's required to understand whether you're disclosing for yourself or to build the relationship with the patient in some way. And I think that can be the tricky part for some people if you're kind of caught up in the situation or like the emotionality of it. That can certainly, you know, prevent your prefrontal cortex from working well and maybe not saying the thing that's actually going to help you with connection. So those are my thoughts.
Thanks. Yeah. Okay. And can I, well, Terry, before I have you go, can I just say something really quickly? So, two thoughts. So the first is, you know, one of the things I sometimes will say in talk is like, you know, am I disclosing for myself? Am I disclosing for the patient? Am I disclosing for both of us? I would argue that I don't believe that we ever are truly only disclosing for patients. And part of that's because it gives us meaning for ourselves as providers to help people. And so I think that, yeah, I think that there's always at least some aspect of self that exists in there. And I don't think that's a bad, and I think we feel like I feel like it's framed as a bad thing, but I don't actually think that's bad. Yeah, so I said that. I'll let Terry go, please.
Oh, okay. I want to make sure I wasn't muted because I'm often muted. Hi, I am really enjoying this. In fact, I texted some people going, okay, I'm gonna need to go see my therapist after this lecture. It's been just wonderful. But I want to say two things about disclosures. So I'm in a weird space where I'm returning to academia after having left in 2004. And I left because I had significant burnout, depression, and loss of my identity. And was very clear that it wasn't a safe place for me. So I came back in 2023. So I'm in a re-entry phase now, but very clear who I am. And so I've been doing a lot of lectures with health staff about fully disclosing my journey with burnout, what that looked like, how it impacted my marriage, how it impacted my role as a wife and a mother, and how much I could have lost had I not been able to address that. And I've been surprised at how being vulnerable and with learners, even as they're attending in those spaces, has really opened the door for them to feel more transparent because they see the attendings one way and they don't realize but I don't think if I had ever left and come back, I would ever feel safe to disclose it, because you talked about subtracting parts of our identity to adopt this new identity. So I feel like I navigate that all the time. I also have a child with special needs. So when I came back to palliative care fellowship after 20 years, I found myself probably oversharing with families like, yeah, me too, I can get health insurance, and me too, I know what it's like to be told that your child can't. So I do think that you have to be aware of that as you're trying to find what you have in common. And I definitely have had encounters where these types of disclosures didn't land the way that I thought they would. But in terms of disclosing more with learners about boundaries and balance, I have found that to be really, really a very refreshing experience this second go around in academia, particularly for my learners.
Thank you, everyone. I love all these comments. I want to return to the story of the person who when I disclosed this thing in clinic about my mental health and taking meds, and that patient was a few weeks later ended up being hospitalized. And I went to go see them one weekend and just kind of check in. And the patient, he sort of brought up this conversation that we had before. And he said, you know, when I first met you, I always felt like there was something about you that was like different, that was like special. And in the moment that you said this thing about your mental health, like he said, I told my mom on the way home, I was like, that's it. Like, that's the thing about this person that's special. And I share this story, one, because it makes me feel warm and fuzzy, but two, to say like, there are these moments where disclosing it requires vulnerability. I believe it should be done very calculatedly and thoughtfully. And there is risk of us being rejected by our patients from the things that we disclose. And so that can be kind of scary or harmful, but it can just be very healing when it goes well. And the same patient, he's one of my favorite patients and he was telling me about he has type 1 diabetes and how he was in the hospital and someone came up to him and said, I'm an expert in diabetes. And he said, how? Like, how are you an expert in diabetes? And the person sort of talked about all their their qualifications and whatever. And he said, if that person had told me that they had type 1 diabetes or their child had type 1 diabetes, I would have had much more trust in them. But that's not what they said. And obviously I'm giving you all a very pro disclosure sort of leaning side of things, but yeah, I really do believe in it when it's done thoughtfully and intentionally. And yeah, I think that we should talk about it more. We have time for one closing comment if anyone would like to. I would love if someone disagrees, actually. I would really be very happy to hear a different perspective than mine.
I was just going to jump in, not to be I like to harmonize. I don't really like to disagree, but we were doing a end of life nursing education with our nurses. This is kind of in response to Catherine's comment about disclosure, nurses disclosing and how this would be a good talk for them. And I learned from our nurses here that there's I don't know if it's coming from nursing leadership, but there's different boundaries that they are required to have. And I don't know if this is the same at other institutions where they are not allowed to have any form of communication with families after their child dies, is what they were telling us. And maybe there's some miscommunication, but it made me realize that that different disciplines, I think, have different teaching about boundaries, and there probably are some reasons why that's the case. Even in talking sometimes with my social work colleagues in palliative fellowship, that the teaching around boundaries is different. And I don't know that means that changing the way you interact about boundaries should be different, but I think there could be kind of more resistance from different disciplines. And it would be really interesting to have even more interdisciplinary presence to talk through this and kind of get the bigger picture perspectives, because I think especially the nursing relationship is so close moment to moment. So I'd be interested to know what people had to say.
Thanks. If anyone has any thoughts, I would any comment, any response that I would love.
I just wanted to make one quick comment. This was amazing, Justin. Obviously, you still have people captured at 1 minute after the hour, even when we all probably have to go back and see patients. So this is just incredible. Thank you for opening our minds and just starting a conversation, I think, about something that probably we all have thoughts about, but I don't think there is a palliative perspective on disclosure. So we get to start deciding what it is today with you. If you all can, I put a link to just a very simple Google form in the chat to fill out an evaluation for today, and we'll send those to you, Justin, for your promotion. And I'll stop there and say, if people want to stay on and continue chatting, that is wonderful. But just a huge round of applause and gratitude to Justin for joining us today, for sharing your story and for sharing your wisdom.
I would just, I'm a nurse practitioner, and I just wanted to kind of share or talk a little bit about what Brittany said too. I think that in my experience in peds oncology and then palliative care, disclosure comes with power. Power comes with disclosure. So when, in my experience, when a physician discloses, there are very few people that are going to tell that physician not to disclose. When a nurse discloses, there may be a number of people that will share with a nurse or a nurse practitioner that maybe they shouldn't disclose. So I think there are pieces of power that go with the disclosure. And then I think, as Brittany said, the amount of time that nurses spend with families, like the things, in case you're wondering, the things that a bedside nurse knows about those parents are things that their family doesn't even know about those parents. And that's true, I think, for many people on the healthcare team. So I think it is different. And I think, yeah, that this could be a whole day seminar when you look at, even as Linda shared, from a psychology standpoint, from a social work standpoint. You know, the social workers that I worked with over my very long career just didn't find things to be questionable. The answer was simply, no, we don't do that. And so then how does that affect our relationship with our patients and families? And I really hear what you're saying, Justin, too, that maybe we're doing a disservice by not disclosing. So I think it's, the other thing I'm just hearing, and I'm just going to say, is that I just feel like disclosure is the new word for boundaries, which is the new word for professional relationships, which I think we just keep calling it something else because we're so very uncomfortable in talking about it and how it affects us and our patients. And this was.
Oh, that's great. Do we have another minute, or do you want me to shut up? Can you hear me, first of all? Yes? Okay.
I'm here for a minute.
You're here for a minute. So I'm a physician and I work in peds onc and peds palliative care, and I do ethics and all that garbage stuff. I think at least at our hospital, the infrastructure of the nursing disciplines and social work, and I don't know enough about psychology, psychiatry to comment, are different from the rules and regs that people sort of assume or are written down for physicians. And I think that nurses have a much clearer structure around boundaries, whether it's good or bad. I'm not going to say, but have a much clearer structure and are much more coming from above. There's much more almost rigidity about not crossing those boundaries. And I think in my world, either that rigidity is not there or I've just ignored it and done it anyway, which is highly possible. But I do think that the structure coming down from above is different. And so whether it's the discipline and the closeness, and whether nurses being closer to patients puts them at higher risk for crossing those boundaries, I don't know. But I do think there's an overall difference. And I don't think it is so much power and hierarchy as it is just a total different structure than nurses. Structure and rules they put together for what they think are professionalism and protection of the nurses. And I'm not, and frankly, in our hospital, nurses have more power than doctors. And so I don't think it's just a power thing here, and every place may be different.
Yeah, I mean, this is ripe for studying.
Studying, discussing, doing seminars, there's a lot here.
All right, I think I will thank you all very much for joining me, for giving me all your thoughts. It's really fun. Thank you for letting me join in your space. I feel very grateful.
Thanks, Justin.
Thank
I
you,
just sent you an
Justin.
email. Let's plan a full